tickets I've forgone.
Hello, and thank you for attending the 2022 Safer Summit. Please welcome your MC for the event, Tony Militello.
Good morning, and thank you for joining us for day 2 of the Safer Summit. As a reminder, my name is Tony Militello, and I'll be serving as your MC throughout the rest of the event, as well as moderating the panels today. I'd like to go over some quick housekeeping notes again. First, you likely saw the earlier posts in our chat function about our ground rules for discussion here today. In short, we encourage you to participate and share your thoughts. There will be several points at which you'll be asked to do just that. But we want to remind you to be respectful and conscientious of your language on what can oftentimes be a challenging set of conversation topics. Second, our pre-event PowerPoint shared some information on tech support. Please refer to the support tab on the top of the event page for more information, or email nscsupport@mac-av.com for assistance. We have a very full schedule today, so without further ado, I'd like to get us started here by introducing our keynote speaker, Dr. Greg Vanichkachorn. Dr. Van is an occupational and aerospace medicine physician at the Mayo Clinic. Among the hats he wears, he is the section chief for transportation medicine and medical director for Mayo's first program for COVID long haulers, the COVID Authority Rehabilitation Program. He also is the host of the Mayo Clinic's aerospace medicine podcast called Clear Approach. Prior to his work at Mayo, he practiced in Northwest Montana for nearly a decade, helping injured workers recover their function and lives. Dr. Van graduated from Cornell University and then pursued his doctorate at Virginia Commonwealth University. He completed residency first in family medicine with VCU and then occupational medicine at the University of Pennsylvania. He also obtained a master's degree in public health from the University of Washington here in Seattle. Outside of medicine, he's an avid fly fisherman, an iron triathlete, and a private pilot. Today's presentation will take almost the entire length of the time that we have allotted today, but there will be plenty of opportunity for you to ask questions during a question and answer period. We ask that you put those questions in the chat function like you did yesterday, and those will be presented to Dr. Van at the end of his presentation. Without further ado, Dr. Van.
Well, good morning, everybody. Thank you so much for that wonderful introduction. It's my pleasure today to be able to talk to you about a challenging and new condition that we have been dealing with over the past 2 years. And that condition is long-haul COVID, or what we call post-COVID syndrome here at Mayo Clinic. So here is the plan for today's talk. First, I'm going to go over a little bit the clinical presentation of this condition. I'll talk about the risk and prevalence of long-haul COVID. We'll go over the biological plausibility of this condition, talk a little bit about treatment, and then finally, we'll go over the occupational challenges associated with long-haul COVID. I like to set the stage a little bit, though, with a story, a clinical vignette, as we call it. So this is a patient that we are waiting to see. He works as an ICU nurse, and about 6 weeks ago, he came down with COVID-19. And fortunately, his acute infection was pretty mild. Didn't have to go to the emergency department or even visit with his primary care provider. But things really went downhill when he tried to get back to work after his isolation period ended. When he went back to work, he found himself suffering from fatigue and troubles thinking. Oddly enough, he also had some new food sensitivities. And because of all of this, he really wasn't performing well, even so much that his supervisor noticed. With this, he developed also anxiety. And by the time he comes to see you, he had actually been off of work for 1.5 months at this point. So this is the challenge that we are facing on a day-to-day basis when it comes to long-haul COVID and work. So how do we address this challenge? Well, let's first go by understanding the basics about long-haul COVID, again, what we call post-COVID syndrome here at Mayo Clinic. So what is long-haul COVID? There's a couple of different definitions floating around out there right now, but overall, the state of long-haul COVID is when someone experiences ongoing symptoms following their COVID infection. What kind of symptoms? Well, what you can see here in this diagram is a description of one of the first, the description of long haul COVID symptoms coming from one of the first articles about long haul COVID published all the way back in 2020 in the Journal of the American Medical Association. And there are a lot of different things in this upside down Christmas tree, but I've highlighted here at the very top the two most prevalent things that we see: fatigue and dyspnea. Now, it's important to remember that fatigue in long haul COVID is quite profound. So, for example, patients will often state something like they do something really simple, like take out the trash, do a load of laundry, take the dog for a walk, and they will experience fatigue and flu-like symptoms that are severe that last for hours or even days at a time. Now, dyspnea, shortness of breath that we see with long haul COVID, that can happen with activity, but also at rest. This description fits very closely with what we have seen in our own clinic. And as was mentioned in the intro, I have the pleasure of being the medical director for our COVID activity rehabilitation program, affectionately known as CARP. And if that seems ironic, yes, I did design that on purpose. I'm an avid fisherman, so I wanted to name something after a fish. So here we are. What you can see here in this slide are the most common symptoms that we found in the first 100 patients that presented for care at Mayo in the CARP program. Right at the very top are fatigue and respiratory complaints. But what you can also see on the slide is that there are a lot of other things that we see quite frequently as well. So for example, neurological symptoms like headaches was equal in prevalence to the respiratory symptoms. 45% of patients reported troubles with their thinking, otherwise known as brain fog, and we'll talk a little bit more about that later. We also hear a lot about sleep problems as well as mental health symptoms. Now, while these are the most common symptoms that we see, there's also more unique, but certainly not rare things that we encounter. So for example, many patients report new onset ringing in the ears known as tinnitus. Some individuals have prolonged loss of taste and smell. There could even be hair shedding, sometimes occurring several months out after an infection. We've had people pass out. Some people complain of sinus discomfort, like they have a sinus infection, but nothing is there. And most recently, we've been hearing a lot about GI symptoms, abdominal pain, nausea, food sensitivities. The main takeaway from these two slides is that long haul COVID really is more than just fatigue and shortness of breath. It seems like every day we're learning about more and more symptoms that can be associated with this condition. Now, a question that I often get is, who gets long haul COVID? And most people assume that it's only those folks who had a really bad infection of COVID that are going to get long haul COVID, and that's partially true. In a study back in 2022, August, that looked at 732 patients to see if there was any relationship between the type of acute infection and the risk of getting long haul COVID. Researchers did find that having a severe infection, a severe acute infection, puts you at higher risk of developing long haul COVID. However, what's important to note from that study is that 56% of those 732 patients of long haul COVID reported having a mild or even asymptomatic acute infection. So in other words, yes, having a severe acute infection can make you more prone to getting long haul COVID, but it's not a requirement. And again, this fits very well with what we have seen in our own patient population. 75% of our patients in the CARP program did not have an acute infection. They were either mild or asymptomatic. Other unique quirks about our population: the average age of our patients is 45.4, which is younger than the groups that we would typically associate with bad outcomes during the acute infection. Another thing to note is that 68% of our patients were female. Now, at first, we thought this was kind of a fluke, but this has actually been repeated in several other research studies. As for other risk factors, there has been some recent research in this area. In June of 2022, researchers went back and looked at the data for 1.1 million patients with long haul COVID. And they found that these risk factors were associated with development of the condition: advanced age, female gender, white ethnicity, elevated BMI, asthma, and of course, having poor pre-infection health. As for another question that I get quite frequently is, how frequently can we expect long haul COVID to occur? Well, the CDC produced the latest information about this, and they went back and looked at the data from millions and millions of individuals who reported having long haul COVID to see if they could identify an overall prevalence. And what they have found is that under the age of 65, 1 in 5 adults can be expected to develop long haul COVID after having the acute COVID infection, or roughly 20%. Unfortunately, those odds get worse as you get older. Over the age of 65, the rate goes up to 1 in 4, or 25%. All right, what about prognosis? Well, unfortunately, as I mentioned at the very beginning, we have been dealing with this condition now for more than 2 years. And so we do have some data to show how people are doing over the long term with this condition. So for example, in this study that looked at about 1,300 patients with long COVID, 12 months out after their infection, almost half of patients reported at least one ongoing symptom. Probably not surprising, during that time period, the amount of anxiety and depression also increased over that time. So unfortunately, the name long haul COVID does sound appropriate for this condition. So we've done a brief overview now of the symptoms and the prevalence of long haul COVID, the risk factors and such. And when many people hear about this, their first reaction is, this is impossible. How can a virus cause so many problems across so many different body systems, And this is an understandable reaction because it is quite amazing. But as amazing as it seems, this story of a virus causing prolonged problems after the acute infection is not a new one. This is actually a sequel. If we go all the way back to the 1918 Spanish flu, studies at that time showed that almost 20% of patients had ongoing fatigue after the initial infection. We've also seen similar things with the Ebola virus, as well as with Epstein-Barr virus, which is a classic cause of mono, which we all know causes prolonged fatigue. More specifically, if we go back to the previous coronavirus outbreaks, SARS and MERS, research at that time showed that almost 60% of patients could be suffering from fatigue 12 months out after their infection. Now, in addition to this historical precedence, we also have some growing evidence that there is something going on a biological level in long haul COVID. So for example, in a study that was done at Northwestern Memorial Hospital in Chicago, researchers looked at the blood work from patients who had long haul COVID 6 weeks after their infection. And what they found was that these individuals, compared to people who had recovered from COVID normally, they had reduced effectiveness to develop protective antibodies in their immune system. Likewise, at the University of Arkansas, researchers there found the presence of unique autoantibodies that we have not seen before against something called angiotensin converting enzyme 2, which is a very important enzyme in our body. Interestingly, this was found primarily in those folks who had a very severe acute infection and was not found at all in patients who had not come down with COVID. Likewise, we also have some information now that there can be a neurological problem associated with COVID and long haul COVID. So for example, in November 2021, researchers did advanced imaging on the brains of 42 patients 90 days after COVID who were still asymptomatic. And what they found was not things like brain tumors or massive changes like associated with a stroke, but they found small changes in how the brain was connected, the functional connectivity, how it processed information. In addition, there were subtle white and gray matter changes. And then there's also research such as this. This is the kind of stuff that unfortunately keeps me up at night right now. Now, this is a very small study, but in February 2022, researchers looked at the tissue of patients, the brain tissue of 10 patients that had died from long haul COVID. And what they found in that tissue were changes that were consistent with Alzheimer's disease. In fact, exactly the same. Now, again, this is a small study, but it does raise a question: are we going to see some early Alzheimer's dementia type symptoms or conditions as part of long haul COVID in the future? Only time will tell. Now, I wouldn't be doing my job as an educator if I didn't mention that, yes, there is also some counter evidence out there. So for example, consider this data, which comes from a study in August of 2022, where they looked at 171 patients and put them through a wide battery of neurological tests. And what they found was that there was rare objective evidence for any kind of neurological pathology. They also found enhanced or elevated levels of somatization, and the patient's symptoms appeared to be associated with pre-existing psychiatric conditions. So maybe long COVID is all due to a mental health condition. I personally do not think so, but time will tell. In any case, though, what it's important to remember is that there is evidence that a biological pathology underlies long COVID. And we shouldn't just assume that everything long COVID is a manifestation of anxiety, depression, or something like a personality disorder. All right. So with that, let's talk a little bit about the treatment that's involved with this condition. Now, I do have to give a bit of a caveat. There's currently no gold standard for treatment for long haul COVID. The program that we have developed at Mayo Clinic is based on the combined expertise of multiple different medical experts in multiple fields, as well as drawing on our experience with treating individuals with work-related conditions. But somewhere else may do something different. When we look at the overall treatment process with long COVID, we divide the treatment into 3 distinct phases. First is the post-acute phase, which occurs between 0 to 4 weeks after an infection starts. Then there's the early long-haul COVID phase between 5 and 12 weeks, and then the true long-haul COVID phase, which is 12 weeks, 3 months or more out after the infection. In my program, my work, we primarily work in the area between 5 and 12 weeks, with the hope that if we can intervene earlier with these patients, we can help prevent them from having long-term sequelae. Zooming into that 5 to 12 week period, our program can really be broken down into 4 different steps. And I'm going to review these in brief for everybody. So step 1, we start with an in-depth interview and psychosocial support. Then we move on to step 2, which is looking for any other conditions that could be causing the patient's symptoms, especially serious ones. After that, we do what's called a targeted evaluation, looking at areas and looking for conditions that we see commonly associated with long-haul COVID, and that is followed by rehabilitation. So let's dive in a little bit here. Step 1, psychosocial support. If there's one universal thing that I have seen amongst all patients who have long-haul COVID, it's that they feel abandoned. And it is unfortunately very easy to see how they may feel this way. Not many people out there know about long-haul COVID. That includes medical providers, family members, friends, and so forth. And so patients who are suffering these prolonged symptoms, they often get told some very unhelpful things, such as this is all in your head, or what you're explaining can't be possible. Probably the worst thing is that you just need to suck it up and get with a program like the rest of us. Because of this, patients with long-haul COVID often have guilt and self-doubt, and that can lead to depression, anxiety, even PTSD in some folks. So the very first thing that we do for patients, and what I would say is probably the most important thing, is that we listen to them and let them tell their story, and we listen with empathy. After the patient has gone through their experience and shared all of their strange symptoms with us, we let them know that this is a brand new condition that we are working with, and that their symptoms are consistent with hundreds of other patients that we have been helping with long-haul COVID. Patients are striving for this validation because many of them, they come to us, frankly, questioning their sanity because they've been told that everything is in their head. This is truly one of the first therapeutic steps in treating long-haul COVID. All right, step 2, after we've established that, we will go on to rule out other conditions. And why is this important? This is important because things can go really, really bad in the first few weeks after an acute COVID infection. Perhaps the most alarming information comes from a study that was done in Michigan, where they looked at 1,300 patients to see how were they doing in the first 60 days after discharge from the hospital. What they found is that almost 11% of the patients who were in the ICU went on to die, almost 7% of the patients who were in the general ward went on to die, and 15% were readmitted. So again, we do a very in-depth evaluation at the get-go. Our visits last about an hour long, and we do some diagnostics just to make sure nothing else is going on. Things like a blood clot, undiagnosed diabetes, pneumonia, a stroke, or something similar. Now, step 3 is our targeted evaluations. And why do we call it this? Well, we tend to see conditions associated with long-haul COVID falling into 4 different buckets: pulmonary issues like pneumonia, neurological issues like autonomic dysfunction or headaches, cardiovascular issues, particularly myocarditis and pericarditis, which is inflammation of the heart muscle or the lining of the heart, as well as psychiatric issues. Now, the reason we call this targeted evaluation is that while we see a lot of these things in patients with long COVID, we don't see them in everybody. So for example, some patients with long COVID don't have a breathing problem, so we don't go into the breathing bucket, the pulmonary bucket, unless we have to. Now, don't have enough time to review everything that we see associated with long haul COVID, but I just wanted to highlight for this group 3 different conditions that we see commonly in long haul COVID. First up, psychiatry issues. Understandably, many patients who come to visit with us are experiencing significant anxiety, depression, and as I said earlier, sometimes even PTSD. Many patients are very hesitant to talk about these kinds of symptoms because, again, they've been told that their symptoms are often all in their head. But I remind patients that the mind and body work together and that we have to treat both in order to treat their long haul COVID, and that just because we are treating anxiety doesn't mean that everything they're experiencing is from anxiety. Now, treatment can fall into 2 different forms. First is therapy. So we try things like cognitive behavioral therapy to help people adapt and cope with their illness. But sometimes we have to use medications, such as antidepressants like Effexor or Cymbalta, as well as sometimes sedatives if someone is having a severe anxiety. Another thing that we see a lot of are sleep problems, either sleeping too little or too much. Now, for whatever reason, we've had a lot of patients get diagnosed with obstructive sleep apnea as part of long haul COVID. Now, we don't know what the cause is or relationship is at this point. Is it because people who have long haul COVID are more deconditioned, they gain weight, and that leads to obstructive sleep apnea? Or are we simply just testing more so because people are reporting sleep difficulties? Either way, if someone does have undiagnosed sleep apnea and they get treatment for it, it can be life-altering for them. On the neurological side of things, one thing I want to note is that many patients with long haul COVID can have prolonged disturbed taste and smell. And we all know that this is something that can happen during the acute infection, but in some folks, almost 40%, they can go on to have prolonged problems lasting for several months. Now, the good news is that most of the time, this is going to get better with time. In fact, only 5% of patients report still having troubles with their taste and smell 6 months out after their infection. But I got to say that can be quite a miserable 6 months. Now, why am I highlighting these 3 conditions? Well, I'm highlighting them because they are associated with safety. So individuals who are on sedatives may be more prone to having accidents at work. People who have obstructive sleep apnea and who are not, who are falling asleep behind the wheel during the day may not be the best people to be commercially driving. And for taste and smell, well, sometimes we'll rely on that very heavily in order to make sure our environment is safe. For example, there's not a fire, there's not a gas leak, or we're not smelling exhaust coming into an airplane cabin, for example. So some things just to be aware about in your employees who may be experiencing these kinds of symptoms. All right, step 4, rehabilitation. We know that people with long haul COVID, or excuse me, people after COVID can be very deconditioned. And in fact, some studies show that 41% of patients have reduced exercise capacity after having a COVID infection. And that just doesn't limit their exercise activity, but they also have limitations with their normal activities during the day, such as walking any kind of distance, using stairs, lifting, sometimes even tolerating screen work. So what do people do about this when they experience this? Well, they usually lace up their sneakers, they turn up their 80s movie training montage music, and they hit the gym in an attempt to no pain, no gain their way back to recovery. And this pattern seems to be particularly common after COVID. And the reason for this, based on what we have seen, is that people after COVID, they are sick of being sick. And it's kind of easy to understand this, right? You got the whole pandemic that's been going on for 2 years. Then you finally got COVID. Then you're in isolation and missing work. And then finally you get the green light to go back to life. And perhaps in a way of sort of flexing on COVID and sticking it back to it, people just want to jump back with vigor. So they go back and they do too much. They have excess activity. And that leads to a flare of their symptoms, particularly fatigue and flu-like symptoms. So then they rest, but that leads to more deconditioning and increased mental stress. But hey, they rested up, so they're ready to try again. And this cycle goes on and on and on. And the reason this cycle goes on and on and on for people with long haul COVID is that people with long haul COVID experience something called post-exertional malaise. Post-exertional malaise is severe fatigue and flu-like symptoms that happens after minimal activity. And if that sounds odd, just know that this is something that has been well documented in chronic fatigue and fibromyalgia, two conditions that are very similar to long-haul COVID. In fact, some studies show that 30% of patients with these conditions experience post-exertional malaise after minimal activity. Likewise, studies that have looked at different ways to treat chronic fatigue and fibromyalgia have found that the no pain, no gain method of graded exercise can actually result in a net negative effect in up to 75% of patients. So the takeaway point here for this is that rehabilitation and reconditioning for long-haul COVID does not just equal exercise. In fact, we try to avoid that word as much as possible in this patient population. Instead, what we recommend is something called an adaptive pace therapy. Another way to look at it is low and slow. So we start patients off with very minimal activity and we slowly build them up over time. Note that this is not a simply stop when it hurts type of philosophy. Many patients in between their episodes of activity are resting quite a bit. And so it's very easy for them to do too much. And they only realize they've done too much until afterwards. When I mean gradual. So for example, let's say someone can walk 10 minutes without having post-exertional malaise. We may keep them there for 1 week and then go up to 13 minutes of walking the next week. It's also important to note that this pacing, this low and slow, applies both physically and mentally. So I have some patients that I will tell, you need to take it easy. So please, don't do your normal workout routine. And they say, okay, fine. I'm going to use that time to finally write that book I've been meaning to get to, or balance out my checking account. That also is not going to be helpful, and it's easy for patients to do too much. Now, as you can imagine, it can be really hard for patients with long-haul COVID to understand that they need to go low and slow. So we'll often involve our physical and occupational therapy groups to help with this, particularly our groups that are used to working with injured workers. They are attuned to some of the psychosocial factors and strategies that need to be used in order to help patients go through this process. Now, anytime anyone mentions therapy, the obvious question that comes up is, does it really work? And we do have some data from research that says, yes, it looks good. So for example, in this study of 85 patients with severe COVID who went through 30 to 40 days of treatment, what researchers found was that there was significant improvement in multiple variables. So for example, individuals at the start of the study needed O2, 83.5% needed O2. After rehabilitation, that went down to 8.2%. The number of individuals in a wheelchair went down from 22.4% down to 4.7%. And we have seen similar outcomes with our own therapy programs. Now, you may be wondering, well, what about all of those things that I hear about on Twitter or Facebook and so forth? You didn't mention anything about that. Those would be things like ivermectin, monoclonal antibodies, dialysis, Paxlovid, the vaccine, hydroxychloroquine, and all that kind of stuff. Well, trust me, I've spent a lot of time looking for a magic bullet to treat long-haul COVID, and unfortunately, we don't have one. Yeah. Now, I won't say that all of these things are not worth it and will not work in the future, but what we really need is more research, unbiased research in these areas before we can recommend these kinds of treatments. Most of the evidence that's out there right now is anecdotal. And I can tell you, for every story that you may have heard where someone got fully better with one of these, I've also got a story where someone got worse with one of these treatments. Now, not everything is doom and gloom. Despite everything that I mentioned, some people do get better. And we're currently evaluating our outcomes right now, but I do have some data from our initial experience here to share. What we have seen is that about 20% of our patients have made a full recovery. And these are individuals that started with very limited function, like being unable to walk across their bedroom easily, to getting back to full duty work. What we found was that these folks that got better early on, they got better right around 4 to 6 months after their acute infection. They also started their treatment for long COVID earlier, hence our focus in the 5 to 12 week period. And they had less brain fog or cognitive complaints than the rest of our patient population. Now, again, these are just observations, not inferences, but based on this, we do recommend that patients try to get care as early as possible. All right, so we've gone over what long-haul COVID really looks like on a day-to-day basis. explored how this may be occurring in the body, and talked about treatment. Now, normally, this is where most talks about long-haul COVID end. But really, this is only the tip of the iceberg. The other half is how all of those symptoms changes a person's ability to function both at home and especially at work. So let's get the full picture now by discussing some of the occupational challenges that long-haul COVID presents. So first up, the first challenge is the functional decline seen with this condition. At the time of presentation to our clinic, 34% of patients reported having difficulties with some of the most basic activities of life. So that would be like putting on your clothes in the morning, or taking a shower, or using the bathroom. 82% reported troubles with the more routine things like grocery shopping or household chores, driving, and of course, work. Now, 63% at the time of their presentation, 63% of our patients reported that they were back at work in some form. Now, that may seem very promising and rosy, but it's important to realize that also the average time between infection start and presentation in our clinic was 3 months. So another way to look at this is that 3 months out after a COVID infection, only a little bit more than half of patients were back in work in some form. In addition, of those patients that were back at work, only about 50% were back to their baseline work. The rest of folks needed some sort of work restriction or accommodation. And unfortunately, these functional limitations do not get better with time. In a follow-up study of patients with long COVID 12 months out after their infection done in New York City, what they found was that 40% of patients reported continued problems with their health, 45% reported persistent symptoms, and almost 40% reported ongoing functional difficulties like even carrying a bag of groceries or climbing a flight of stairs or walking 1 block. Similarly, patients experience continued difficulties with their work as part of long COVID. In this study that looked at patients and their employment 7 months out after infection, what researchers found was that the number of people who were fully employed went from 72% down to 44%. The number of individuals who are working reduced hours or were out of work also increased during that time period. Now, for all of those folks who work in the healthcare industry that may be listening today, I do have to highlight that long COVID also seems to be particularly bad for healthcare workers. In a study of roughly 3,000 healthcare workers to see how they were doing after their COVID infection, what researchers found was that healthcare workers have more likelihood of developing long-haul COVID compared to other individuals who have a COVID infection. In addition, their functional impairment because of those symptoms is worse. Now, this may seem surprising, but we have seen this in other studies as well. This may have something to do with the fact that healthcare workers, they're having to go back to face a virus on a day-to-day basis at work that's causing them also prolonged symptoms. And that is a very unique stress and trauma. So this is a patient population that definitely deserves our close attention. All right, moving along. The next occupational challenge that long-haul COVID presents is safety issues. And I'd like to revisit this slide from earlier where I described our most frequent symptoms in a clinic. Again, right up there with the neurological, respiratory, and fatigue symptoms is brain fog, reported in 45% of our patients. So we see this quite a bit. But what is brain fog? So if you go into a medical dictionary and look for the term brain fog, you're actually not going to find it because this is not a medical term. This is something that came up in the media and stuck, as they say. But that being said, despite it being a nebulous term, what we have found when talking to patients about what specific issues they're experiencing as part of their brain fog is that there are striking similarities amongst all of our patients. For example, many patients report difficulties with short-term memory. So they'll go into a room to retrieve something and they can't remember what they were looking for when they get there, or they can't remember simple directions like going from the hotel lobby desk to their room. A lot of patients also report troubles with word finding. They feel like the word is just on the tip of their tongue, but they can't get it out. And also patients report troubles with multitasking. And this includes activities that they have maybe have done for decades of their life, both at home and at work. Suddenly becomes much more difficult and they are much less efficient. Now, again, that's a subjective description. And even though it fits all the way across many patients' description of brain fog, it is subjective. What about on the objective side? Do we have any proof? The answer is yes, sort of. We're starting to see some good research come out about brain fog and long haul COVID, like what you see here. So in February of 2022, researchers looked at 60 patients and put them through a wide variety of tests, including a full neuropsychological battery. That's something that takes about 5 to 8 hours and is very in-depth. And what they found was that individuals in the long haul COVID group scored below normal on many more domains compared to the control group, 8 out of 11 domains versus 1 out of 11 domains. In addition, the percentage of extremely low scores was double in the long haul COVID group than in the control group. Now, what's the point? Well, the point is that the difficulties of long haul COVID by themselves can impair a person's ability to work. So, for example, let's say you work in a cafe, and because of brain fog, you have significant difficulties taking an order from a table of 6 in a loud, busy environment. That's going to definitely degrade your performance. But brain fog and long haul COVID is more than just a performance issue for work. Let's say you don't work in a cafe, but instead you work in this environment. Now, I think when we all consider someone who has troubles with short-term memory, word finding, and multitasking working in this environment, we can appreciate the safety implications of this condition. Now, safety in long haul COVID, that's only something that many groups have started to realize and explore right now. But hopefully, as we get the word out more about this condition and its impact, we can start making headway in keeping people safe, both the public and employees. All right, the next occupational challenge, there are no standards. What do I mean by this? Well, first up, right now, remember, this is such a new condition that we don't even have an agreed upon name yet, even 2 years later. So I say long haul COVID. We also say post-COVID syndrome here at Mayo Clinic. The NIH says post-acute sequelae of SARS-CoV-2, which is just awful. Likewise, we don't have a universal definition either. The most recent definition for long haul COVID came from the World Health Organization back in October of 2021. And you can see the requirements here on the slide. But in a nutshell, in order to meet their definition, you have to have symptoms for more than 3 months after the onset of the infection. And the symptoms have to be present for at least 2 months. And your condition can't be explained by something else. The important nuance here is to realize that you do not have to have symptoms the entire 3 months in order to qualify for their diagnosis. Now, the CDC has an entirely different definition. First, they call it post-COVID conditions, and they pretty much count anything that lasts 4 weeks or more after the acute infection. And that's actually the definition that I subscribe to more so, and Mayo does as well too. Likewise, we have no single objective test for diagnosis. There's no clear symptom groups. Remember, we are still learning about the kind of things that can be associated with this. There's no appropriate test for assessing cognition. And as I mentioned earlier, there is no gold standard for treatment. Now, why does this all matter? Well, it's going to be really hard for us to start addressing the challenges of long haul COVID in the workplace if we can't figure out who really has long haul COVID. Next challenge, this is uncharted territory for employers. Now, there has been some headway made with employment and long haul COVID. In July of 2021, the government finally recognized long COVID as a protected disability under ADA. Now, I know I'm preaching to the choir here, but just to review, what's a disability? Well, it's a medical condition that substantially limits one or more major life activities. And if an employee is suffering from one of these kinds of things, they need to have reasonable accommodations in the workplace. And we are all familiar with this kind of language. So for example, let's just take a very common work-related condition or condition that affects work, low back pain. If an employee has low back pain, employers can expect that they may need to have some work restrictions and limitations. They may offer them temporary alternative duties to get them back on the job site. There may even be job rotations. We're all used to hearing about these kinds of things. But what is a reasonable accommodation for someone who has long haul COVID? For someone who has fatigue with minimal activity, who can't think clearly, and may have ongoing headaches and diarrhea on a frequent basis? Well, unfortunately, I do not have a specific answer. Now, the last time I gave this talk, someone came up to me afterwards and said, Your talk was great, but if there's anything that I wanted more of, it was a slide after the what is reasonable slide for long haul COVID. So fresh off the press for all of you, just updated this week, here are some tips that have helped us get our own employees back on the job after they've come down with long haul COVID. And this is from the occupational medicine physician point of view. Of course, everything that you see here, you'll have to run by also with HR and benefits and so forth. First, it really helps if employees can go back to work in a graded fashion. Something I hear a lot from the employees that I treat is, well, my boss said they don't want me to come back until I'm 100%. I hear this a whole lot. And on the surface, that kind of statement seems very helpful, right? We want you to get fully better. So when you come back here, you're good to go. But on the flip side, what patients often hear is that they can't come back until they are ready to do everything that they need to do at work. And it can be really difficult for patients to make that transition from no work to 100% productivity overnight. So instead, what we recommend is creating avenues for employees to get back with limited hours initially. So for example, many of my initial work restrictions for patients who are coming back to work after long COVID are start with 4 hours of work, 3 days a week, with a day of rest in between. Another thing to consider is letting patients telework initially. Now, telework is a silver lining of the pandemic, in my opinion, and clocking in from home can be a wonderful way to bridge an employee from no work back to starting work. Now, I know what you're all thinking. Okay, well, if we let them work from home at the beginning, they're going to want to work from home forever. Well, that's where you have to have clear communication. And that leads me to my last point here on this slide, communication, or true vitamin C. One of the most worrisome things that I have heard from patients, or I often hear from patients, is when I ask them, how has your employer been doing and helping you with your process? And they say, well, I haven't talked to my employer for 2 months. That's a very worrisome sign. Both the employee and the employer need to be engaged with the process in order for recovery to be successful. So for this reason, we often meet with our patients with long COVID every 2 to 4 weeks, and we provide work status updates that frequently as well. So my recommendation to employers is not to be afraid to be proactive and to reach out to employees, ask them what the latest is, and you schedule regular touch points and communicate clearly why you are frequently communicating. It's not because you're trying to push them back as quickly as possible, but that you're really supporting them as they go through this process. The other tip that I recommend is a culture of support. Now, I put this one last here because unfortunately, this is often one of the most difficult things for businesses to develop. If someone has a very bad car accident and they lose their ability to walk and then they're in a wheelchair, when they come back to work, the general appropriate thing that most businesses and employees will experience is that there is a culture of support. People will help this individual go through this very severe transition and change in their life. Unfortunately, this is not a luxury that long haul COVID has. Remember, there are folks out there that do not believe COVID exists. And it's even more difficult for patients to believe that they have long haul COVID. And because of these views, which everyone is entitled to, but because of these views, it can often lead to things like hostility, bullying, reprimands at work. Trying to face that kind of adversity while also experiencing the symptoms associated with long haul COVID can be daunting and can make the recovery impossible. So I encourage all employers to take a look at their work environment to see, is there anything that can be done to improve the culture of support for this condition, starting preferably from the top down. All right, and now for my final takeaway point here. This is going to be a challenge for all of us because it's not rare. Just kind of give you an idea of the problem that's ahead of us here. As of this month, there have been roughly 95 million COVID-19 cases in the United States alone. If we estimate conservatively that 10% of these patients will come down with long-haul COVID, that's roughly 9.5 million cases of post-COVID syndrome, again, in the US alone. And that estimate, by the way, is half of what the CDC estimates. Based on our research and our experience, we anticipate that 30% of individuals with long-haul COVID are going to have prolonged difficulties with their ability to function. So that's 2.85 million people in the United States alone unable to function normally because of long haul COVID. And these are not just nameless numbers, right? This 2.85 million people includes teachers, firefighters, police officers, physicians, baristas, factory workers, you name it. So this condition of long haul COVID, it's more than just a healthcare challenge. It's a challenge for our economy and our society. And that leads me to my final point for this whole talk. We are at the very beginning of understanding this condition. And until we have a better idea of what is really going on inside the body, we need to be very careful about deciding what is and isn't long haul COVID. And we need to remember that just because something is unexplainable does not mean that it doesn't exist. Only by keeping such an open mind can we get patients the care that they need. Can we get them back to their livelihood? And can we change this condition from being a challenge to being cured? And with that, I will finish up here and leave my contact information. And I have some time here to take any questions that may come in. Thank you for your time.
Great. Thanks, Dr. Van. Again, appreciate your presentation here this morning and again into the early afternoon in some locations. The audience has been very active in the chat function, and so we certainly have a long list of questions that we suspect we can get to over the next 25, 30 minutes or so. Some of them may have been covered, at least briefly, but I'm going to go ahead and ask some of them, or all of them anyway, and again, to the extent that we can go into depth a little bit more about the specific questions, that would be great. The one question that was one of the first questions that was asked is, what's the transition period between original COVID and long haul COVID? How long do symptoms have to occur from the initial infection for the symptoms to be considered then long COVID?
Mm-hmm. Great question. I would say that based on our experience, almost everybody has symptoms that continue after the acute infection. There are some folks who might have a gap of a few weeks, but that's a rare scenario. And what we have not seen a lot of are individuals who present like 4 or 5 months after an infection of having no symptoms and then have long haul COVID symptoms and get diagnosed with long haul COVID. So it should be relatively close to the time of infection, in my opinion.
Great, thanks. One of the other ones, again, related to the symptoms from some of the research that you talked about or some of the results. Could you go into a little bit more depth about the differences in what you've seen in terms of those that were vaccinated versus unvaccinated? Again, just maybe a little bit more about, certainly heard about what some of those results were, but was there further delineation about the differences between vaccinations and no vaccinations?
Yeah, no, that's a great question. So first up, it was hoped that people who got vaccinated would not get long haul COVID. Well, that certainly is not true. We have seen plenty of cases where individuals are fully vaccinated, they still get a breakthrough COVID infection, and they develop long haul COVID. So that's a possibility. What we have seen based on our experience, though, is that individuals who are vaccinated, they tend to have a different, perhaps less severe symptom profile. We're actually going to be publishing some research on this probably in the next few months. And they also seem to get better compared to individuals who get better faster compared to individuals who are not vaccinated. Now, this is very early research, though, and there's going to be a lot of things that can affect this outcome. So, for example, we know that individuals who are vaccinated also tend to get care sooner versus later compared to other groups who are not vaccinated. So are they getting better faster because they're vaccinated or because they're getting care sooner? Who knows? But in any case, the best way to not get long COVID is to not get COVID in the first place. And of course, I recommend the vaccination. Another interesting tidbit that I'll throw out there is that we've had some patients get better after getting a booster or a vaccine. And this is not completely just off the wall. There's some thoughts that perhaps the vaccines reset or reboot the immune system, and that it's able to clear out any problems the immune system has had because of the acute infection, and then they get better.
Great, thanks. One of the next questions talks about some curiosity or some potential explanation for the fact that women are more present in long COVID. Do you think there's any relationship to the fact that women may be more likely to seek help, particularly for mental health issues?
Yes. Yeah. I think there's probably two different components at play here that result in that phenomenon. One, there may be the socioeconomic thing, right? That female patients may be more willing to go seek care for this condition. However, we've also seen the female gender be associated with other things, other medical conditions that can be related, such as autoimmune conditions like lupus and so forth. And we do think that the central problem with long haul COVID is that there is an autoimmune or immune system abnormality. The immune systems are different between males and females, mainly because of the child rearing ability of females. They have typically a stronger, more reactive immune system as a protective measure. And so that may be explaining also some of the differences or predominance of female gender we see here.
Great. One of the other symptoms that we heard somebody talk about some of the symptoms that may be associated with either regular COVID or long haul COVID. And so one of the questions that came in was from a participant that says that they do hearing tests at their facility and have heard of increased tinnitus following those having COVID. This individual also said they experienced tinnitus themselves. Is there anything that you have heard or experienced about potential hearing loss, whether it be short or long-term hearing loss?
Yeah. So first up, to answer the question about hearing loss, we have found a few cases where individuals have new onset, objective, full hearing loss in one of their ears. We actually published some research on this recently, and you can Google that. But yes, that is something that we have unfortunately seen, and we have no way to get them back their hearing, unfortunately. Much more commonly, we hear about the ringing in the ears, the tinnitus. And, people throw around that term a whole lot. Tinnitus, it just sounds like a kind of a silly thing. But in reality, it can be a very, very disturbing condition. And there's not really a lot of treatment out there other than helping patients cope with this or covering it up. So it's something that we take quite seriously. We often will have our patients evaluated by ear, nose, and throat groups. So I would say that if you hear someone who has tinnitus or you're experiencing it first, I wouldn't blow it off. This is definitely something that we see, and you definitely want to speak to a provider to see what can be done to help you with your symptoms.
Yeah, great. Thanks. I mean, that certainly is another area. And again, you've talked about getting medical care, or getting, whether that be physical medical care or psychological medical care. Again, I think all those types of things, at least certainly in my experience, all those things are going to contribute to what the profile might look like for the reasonable accommodations that you talked about. So again,
Yes.
certainly support
Yeah.
your recommendation there that don't blow it off, and don't kind of shrug it off as being just something that you're going to have to live with. And those are things that there are reasonable accommodations to address all those types of things. Again, whether it be from a medical condition like COVID or some other reason. So again,
Right.
certainly endorse that recommendation clearly.
And if I
You
may
talked a little
add,
bit about,
for those groups who may
please.
be running a hearing conservation program, again, I'm an OCMED doc by training. So if you have a hearing conservation program, someone has a massive change in their hearing, don't be afraid to ask about COVID and those kinds of things, because it may not be a work-related threshold shift.
Yeah, great. Thanks. And you talked a little bit about the relationship between COVID and specific heart issues. Could you give another just quick summary and kind of a snapshot about the differences between regular COVID, maybe and long haul COVID, and what effects those may have on heart conditions?
So if you go into the research and you look at ramifications of COVID on the heart, you can find all sorts of really worrisome words and diagnoses like heart attacks and blood clots and things like that. Yes, someone who has a COVID infection can be more prone to having a blood clot. Yes, we see a whole lot of inflammation. Okay, no, that's not true. We see a fair amount of inflammation of the heart, either the lining of the heart, called pericarditis, or the heart muscle itself, myocarditis. The typical symptoms are going to be chest pain and exercise intolerance. But despite that, those worrisome terms, the treatment is typically rest and taking things nice and easy for a couple of weeks while going through anti-inflammatory treatment. So we have not seen more severe outcomes where folks are like healing over from a heart attack or something like that, or suffering a massive pulmonary embolism because of COVID. These are things that can happen during the acute infection, but sometimes they can linger also and only come up during the long haul COVID phase as well too.
Great, thanks. Again, classically and certainly for great benefit and great value, you've referenced a variety of studies. In some cases, you've certainly used the term objectively and subjectively in a couple cases. And like you said, as an educator, you presented both sides of many of those research results. So a question came in a little bit around that asks, are there other non-bias studies currently ongoing to find possible remedies for long COVID?
Hmm. Mhm. Yes and no. I guess I will say. So, unfortunately, research for long COVID is moving along slowly. It's such a new condition that most of the research out there right now is really focused on trying to identify what the symptoms are associated with this condition. There hasn't been much research, at least published yet, that is looking at treatment outcomes for this condition. But many things are in process or in place. So, for example, I know that there's a couple of Paxlovid studies by major medical centers that are going into this. So, I do expect that with time, we are going to have more unbiased results regarding treatment and research.
Great, thanks. Questions just keep coming in. The next one here, it gets a little bit back to vaccines versus unvaccinated. So the question becomes, is there some evidence that may suggest that the treatments, either the vaccines or the treatments that people may have undergone for regular COVID actually contributes to the prevalence of long haul COVID? Is there any relationship there?
Yeah, no, I have not seen anything in that realm yet. Fortunately or unfortunately, depending how you want to look at it. What I've seen is that markers of increased inflammation during the acute infection have been associated with long haul COVID, but that's not usually due to some treatment measure as far as that we can tell. It's more related to the actual infection itself.
Okay, great. Another one, again, staying on the vaccine topic, you had mentioned or at least what I thought I heard in response to an earlier question was that the people that have symptoms of COVID or even potentially long haul COVID, once they've received their booster, there seemed to have been a reset in some of their medical conditions. The question came in was, is that just for the kind of physical medical conditions, or has there also been evidence that there's a reset of some of the neurological issues and symptoms that people are experiencing after they've received a booster?
Mhm. And no, we see that for all of the symptoms, both physical, neurological, and mental.
Great. Kind of on the testing front, any tests that you know that either exist or are in development for testing for long haul COVID?
No, unfortunately, not yet. When we run our tests on patients with COVID, they almost always come back normal. One thing that we have seen occur is that individuals can have elevated levels of cytokines, that's inflammatory markers, as part of long COVID, even with some of the more normal tests of inflammation being normal. But again, that's just a small little slice of the long haul COVID population. And so we don't know if that's something that's going to be applicable across the board as a diagnostic measure. So we are far from that. I think what we need to have before we can do that is really understand what's going on a biological basis. Is it an autoimmune problem? Is it an energy storage problem? Is it microclotting? There's lots of great theories out there, but we really don't have an understanding of what's a central component that's leading to these symptoms. Once we get that, then I think we can finally get that diagnostic test.
Great, thanks. I've got one more question, but and we've got a little bit of time left for the audience. So if the audience has any more questions that they would like Dr. Van to address, and we've got a little bit more than 15 minutes or so, and I've got the final question here that's been forwarded in the chat. But if anyone has any more questions, again, certainly feel free to put those in the chat, and we will get them over to Dr. Van. Dr. Van, the last question, at least that I have so far, is about PPE. My organization has a PPE warehouse where we stockpiled personal protective equipment early in the pandemic and looking to repurpose this space within our organization. Curious as to whether or not that might be a wise decision to do.
Okay, that's a good one. So It sounds like the question is, should we make the availability of PPE decrease, right? Now that the pandemic is over, quote unquote. I think because of the pandemic, we've definitely ramped up things quite a bit when it comes to PPE. And so we probably don't need as robust levels as we have had in the past, thanks to the vaccines and the boosters, and hopefully they'll be effective. So I think those kinds of levels, those pandemic levels of PPE storage and availability, we probably don't need. But if there's one silver lining that comes from the pandemic, I think it's also that wearing PPE can be an individual experience as well too, meaning that if you need to wear one because of whatever you're going through, that's okay in public. That's something that we have seen in other countries quite frequently, but only has something changed here recently in the United States. So I would say maybe a moderate, a middle ground, not to get rid of it all, but to keep it easy for people to use if they need to, and keep up levels to allow for that would be my recommendation.
Yeah, great. Thanks, Dr. Van. Again, that had been my experience as well. Certainly when there was a downturn in the infection rates, and certainly there was a repeal of or kind of reduction in some of the mandates in terms of mandating separation distance or personal protective equipment. Exactly to your point, after a year or more of wearing personal protective equipment, face covering specifically, to your point, right? That became a very personal experience for many people, and many people grew to have some level of comfort associated with that. Again, whether it had the desired outcomes, whether it be physical or psychological, again, people continued to want to do that. And so that was exactly why the companies that I was with did exactly what you mentioned, was, kept a stockpile on hand, because again, there's an experience that people want to continue to have that added level of protection for their own benefit. So one last question here that just came in is, have you seen any correlation between Paxlovid and long haul COVID?
Great question. Unfortunately, not. So we've had patients get the Paxlovid and they still develop long haul COVID. I've had some individuals get Paxlovid for long haul COVID, and we haven't seen an outcome with that yet. But again, those are just anecdotal stories. It's not something that we are doing for treatment here at Mayo. But again, there are some research studies out there. I think it was Duke that is doing that, Duke Medical Center that is doing that. So I'm waiting with bated breath to see what the results are going to be of that trial.
Great. Another question is that just trickled in. We talked earlier in the presentation about the susceptibility is greater for those of advanced ages, so to speak. So this question kind of gets on to the other end of that: is how common is it for young adults? Individual clarified that with about the 20 to 25-year-old age range. How potential is it? What's the potential for that age group to suffer from long haul COVID? Any evidence for that?
Yeah, I would say that it's very common. It's so common to the fact that if someone is in that age group and they came to visit with me, I wouldn't even bat an eye about it or think it was odd. We've seen individuals all the way down through adolescents who have long haul COVID symptoms. And we have a group here at Mayo that does treat those kinds of individuals under the age of 18. Things get a little bit more murky when you get younger like that, because often individuals who are younger, they don't have a really good way of or experience in explaining their medical conditions or understanding what they're going to, or realizing that there's an issue until too much time has passed. Whereas individuals who are older and have a little bit more life experience, they're usually quicker to get help if something's amiss.
Yeah, having two individuals in that age grade myself can certainly verify or kind of vouch for that they are slow to seek help, certainly. But
Yeah.
no, I appreciate that. Another one is, we talked about a variety of medical conditions and symptoms associated with either COVID or long haul COVID. One specific question just came in, really looking at the acute symptoms around the eyes specifically. Anything that you've seen with regards to the eyes, such as eye irritation or excessive tearing, or any other types of impacts to the eyes specifically?
Yes, yeah, that's a great question. And the answer is yes. Early on, we had a lot of folks who were reporting things that they said felt like a mild pink eye, which we chalked up to eye irritation. And we would send those folks to get checked out by our eye doctors or ophthalmologists. And at first they were like, no, this is not possible. This can't be happening. But sure enough, as more and more individuals presented for care, they started to look at it more closely. And what we have found is that individuals can have like decreased tearing, which can lead to eye irritation or generalized inflammation. We've also heard that patients can be really sensitive to light. We have some theories behind that as well too. It may even need a different visual acuity correction, a change in their glasses for the time being. Many patients also report troubles with screen time in their eyes following or as part of long haul COVID. So yes, we see a lot of eye issues. I always recommend that patients visit with their eye doctor to make sure there's nothing else more sinister going on and that they might need to change in their glasses. But I will say that overall, the eye symptoms, while they tend to be annoying, they tend to go away with time.
Great. Seemingly the last question, although we may have another one while I'm asking and you're answering this question here. Is there any evidence that the booster can eliminate tinnitus or fatigue?
I have not seen it eliminate tinnitus. I have seen it eliminate fatigue. Now, I just want to be really clear about this, though. I always joke with my patients that I don't want them to go out and just get as many boosters as they can, or to like start licking doorknobs in order to get COVID to try again. So there could be a lot of bad things that could happen from a COVID infection, as I mentioned. So I counsel people to not try to do that route.
Yeah, thanks. You certainly mentioned that earlier too. Is right. The first step is to not get it. And then worry about other types of prevention if in fact that does become the case. So there's. Go ahead.
Oh, if I may add another thing, a question that I get a whole lot related to this is, if I have long COVID and I get a COVID infection, what does that mean? I know there has been some research lately that shows that the more chances you have, more times you get COVID, the more chance you have of getting long COVID, which in a way is kind of like a no-brainer, right? But what we have seen, at least in our clinic, is that if a patient gets a COVID infection during long COVID, they have symptoms that last for a few days, just like everyone else. And then they go right back to where they were right before the most recent infection. We have not seen, I think I can count 2 people who have gotten worse for like 2 or 3 weeks with their long COVID symptoms due to an acute COVID infection. All the treatment that we do for this really is about giving people back their function in their lives. Sometimes we can't get people to go back to where they were at their baseline, at least symptomatically, but we can at least get them back their function. And so what we don't want patients to do during their recovery is sort of isolate themselves in a room of their home so they never get COVID again. We see a lot of that kind of fear. So I remind patients that if you get COVID again, it's going to be okay. And you might even get better. But don't lick a doorknob.
Well, again, I appreciate Dr. Van, again, very thorough and again, well-researched and well-documented and well-referenced presentation this morning. Again, certainly appreciate that. Again, really exceptional responses to the questions as well. So with that, again, ask the audience certainly to give Dr. Van a virtual round of applause. It's certainly in celebrating any way that you feel appropriate. Dr. Van, again, we appreciate your time and again, your really in-depth and expertise and knowledge. And again, thank you for sharing your time with us this morning.
It's really my pleasure to be here. I'm honored to have the chance to speak to this group. If you have any questions after this, something unique that you didn't want to address over the chat, just send me an email. That's the easiest way to reach me. And only by working through all of this together will we get through it.
Great. Thanks, Dr. Van. Have a great rest of your day. So participants, we will transition now to a short bio break, and we will return to this bat channel at 35 minutes past the hour. So whatever time zone you're in, at 35 past the hour, we will return to this regular scheduled program. Thanks, and look forward to seeing you soon.